Let's talk about gene therapy. Now, if you wanted to talk about expensive, we're talking about expensive, right? And we've got lentiglobin BB305 for severe sickle cell disease.
Okay, so before I want to give credit to Sophie over there for teaching all of us with dollars and cents how expensive it is to take care of sickle cell disease for a lifetime. So just putting that frame of reference when we're talking about costs associated with any novel therapy, whether it be disease modifying like we've been talking about so far, or curative intent. I just want to put that disclaimer out there.
Consider it put.
Okay.
Because, but it's a fair one.
$2 billion?
How much does it cost to take care of a sickle cell patient versus maybe we front load this and now we don't have to do that anymore?
I understand. In fact, there should be an understanding of cost of drugs, but frankly, as someone who's dealt with the disease from a public health standpoint, there have been a lot of expensive drugs out there, and there's been no drugs for sickle cell. And CAR-T, I could go through a whole bunch of single drugs that could cost $1 million per pop. And I don't think now that we have a menu to give them, that immediately we should start focusing disproportionately on hemoglobin drugs.
Well, if I want to cure this disease, I got to change the genetics. I'm thinking transplant or gene therapy. So where are we with gene therapy? Help me out here.
We're in an exciting time with gene therapy.
I bet we are. We're in exciting times with lots of diseases. And I don't mean that to just brush you off. I mean that I'm excited. This is great stuff. Where are we here?
So we're in relatively early days. There are several strategies for gene therapy, which all have curative intent. And I say the study that's furthest along is on the order of a couple of years worth of follow-up data, and that there are newer approaches that have on the order of a few months of data. These approaches include strategies to correct the genetic defect, as well as strategies to add genes to also correct the defect.
Let's spell this out. Lentiglobin is a viral envelope, right, which contains genetic material, which we hope the virus then injects into cells, for lack of a better phrase, and that changes the genome of the host. This viral envelope the envelope alone is an HIV envelope, but without the HIV genome, so you're not giving people AIDS or even HIV infection. Is that a fair description? Yes. Because it's gotten a lot of creepy press. Yes. All right. That being said, we have this BB305 drug product. Does it work? How many have gotten it? What's up?
We're early in this process, and they're learning how to do it. They've had 3 cohorts, and the progress and the amount of hemoglobin S has decreased, and the vector has increased over time, and they're improving on their methodology to improve vector copy number and to get higher hemoglobin A in the people who are undergoing the therapy.
Right, because they're adding a healthy hemoglobin A. That's the whole strategy, right?
That is the strategy. The more A you've got in this disease, the better. Fair enough?
Yeah. But the key thing to remember is that you need fully myeloablative chemotherapy in order to get these cells to engraft. And I think that's probably one of the biggest issues, although there are lots of great people thinking about how to change that myeloablative regimen to one that is not myeloablative, so you don't have issues related to fertility and potentially secondary malignancies.
But all the different strategies include myeloablative therapy right now. So just to,
This sickle cell is different than thalassemia, which is most of where the gene therapy has been done, though other diseases are now being done across the field. In thalassemia, you can measure how high the hemoglobin goes up, and you decrease the problem of ineffective erythropoiesis. In sickle cell disease, it's a little more complicated in that while you can raise a healthy hemoglobin, unless you totally correct the level, you really don't yet know what the biologic effects are going to be. And there are markers going on that are encouraging, but actually whether biology of sickle cell has been stopped, we do have suggestions at levels, phenotypes will be improved. And they have done computer modeling about how much is in each cell. We haven't actually measured the amount within each cell yet. But I think it's quite encouraging, and there are new therapies coming out, new modifications. So we're all very excited about it, and I think it offers for patients who don't have a match, HLA match, a really golden opportunity to be treated without the risk of graft versus host disease, because really what you do with gene therapy is you do an autologous transplant, and that's really what you're talking about.
Right, so that it's your own DNA effect.
Yeah, and I think some of the newer technologies that are coming out, eventually the editing and nucleases and other things, if they can improve some of the vector numbers and things, down the line we will see progression where this is going to pan out.
Yeah, I agree. I think the new iterations of the gene therapy now, gene editing, I think they're really becoming more sophisticated with CRISPR, right? The people
I knew
are
CRISPR
using
would
it.
come up
Yeah,
eventually.
you know, it's so important. I think it's just a breakthrough, and so they are now disrupting the genes that inhibit the fetal hemoglobin production, and now all of a sudden you produce a lot of fetal hemoglobin.
They had a press release
That's
last
right.
month that showed the first sickle cell patient that got the CRISPR CRISPR-based gene therapy by month 4 had 46% fetal hemoglobin,
Yeah,
I believe.
yeah,
Was that the
exact-
number?
it's
by month
early.
4? Yeah,
Yeah,
so
it's early but encouraging,
And I
right?
think there's at least some people who believe that the more targeted you can be and more precise you can be about your gene therapy strategy, the less likelihood for off-target effects.
Am I the only one who's amused by the fact that we're quoting press releases as opposed to?
Well, I will say, to that point, you're right, because we're all academics and it probably sounded funny, but I think from spending a lot of time in the patient community, I will say that it is very important that the sickle cell patient and caregiver community have access to this information, and they're not getting it from medical journals. So I actually commend the sponsors of these trials who try to get information to the masses. So
I don't
again, thank
disagree.
you for thank you for clarifying that. But I think it's important.
Completely
You
agree.
know, I was a journalist on television, on the other end of all these press releases. Some great, some not so great. Some guys needed funding, so there came a press release. You got to know who to trust.
I have some concerns. I do think patients should be educated, and I think there is a public awareness. But when the releases come out, still, I just came from a meeting. When you talk about gene therapy, many of the patients don't grasp that they're getting myeloablative therapy. They hear the word gene therapy and they think they're getting this thing. But I do think it needs to be on the table. And, you know, frankly, the drug is, the therapy for non-beta 0, beta 0 has been approved in Europe. And so there is a lot of things that are going to change, and I think they should be informed. I just
Absolutely.
want it to be including the good and the risks.
Well, that is the risk. In other words, if you're going to do this, and that 40% sounds really exciting, all right, did that press release mention the downside? What's the risk? How many were not happy with this? How many failed? What's the data?
So from my interpretation, and this was an NPR, it was the perspective of the patient.
Right.
And so it was whatever the patient said.
That's right.
And so there wasn't really the opportunity for that kind of balance. And like, you're right, Sophie, it was one patient, so how much can you say?